My name is Liesl Nel-Themaat. I am super excited to be back here hosting Saturday Night Live. Sorry, I mean I3. I just hate it when that happens. I3, welcome. I was honored to host the third session almost 2 months ago. And it is truly encouraging to see how many of us since then are back in our labs and clinics providing care for our patients, of course, while we're limiting exposure to the coronavirus. As more of us are getting back to our pre-COVID routines, I3 will be changing to a once per week schedule starting next week. We hope you will all continue to join us whenever you can, as it is our intention to keep providing you with these state-of-the-art, relevant educational events. So please let us know which topics you are interested in and how we can be of help. All our webinars are recorded and posted on our website, so if you missed one, you know where to find it. Now, we have been interested in putting together a session on today's topic for quite some time. I have to give a big shout out to Giles Palmer, who is a panelist today, for his role in conceiving and organizing this webinar. We now lovingly call today's event Our Baby, and hopefully we can create a few more babies together in the future, Giles. But when I found out that Giles was expecting me to be hosting, it dawned on me that, like with my previous session on AI, I really don't know anything about today's topic. So I had to find myself yet another qualified sidekick. And any of you who watched my previous presentation will agree that Alex Parker set the bar very, very high. But I did not have to look very far, as I'm fortunate to have a placenta expert right here in our department at the University of Colorado. Dr. Thomas Jansson, who coincidentally went to medical school with our second speaker, was a very easy choice, and I was lucky that he agreed to do this with me. Dr. Jansson is the Vice Chair of Research at the Department of OBGYN, where he does translational research exploring the cellular and molecular mechanisms of regulation of placental nutrient transporters, as well as investigating the role of placental function in determining fetal growth and long-term health. So he clearly is more than qualified to get the discussion going and ask the right questions. He's also a super fun person, and I am very excited that he's joining me today. So welcome, Thomas.
Hi, everyone. I'm very honored and excited to co-chair this session with Liesl, because today we will actually hear presentations from two scientific pioneers. The premise of the work of the first speaker, Dr. Kemp, is that each year 12 to 18 million infants worldwide are born prematurely. Despite progress in the management of premature babies, in particular, infants born extremely or very premature are at high risk of neonatal mortality and morbidity and long-term sequelae. So prematurity is a problem of profound public health impact that requires a new way of thinking and development of new innovative approaches. And the development of an artificial placenta by Dr. Kemp's group is truly exciting and could potentially change the way we care for premature babies in the NICU in the future. The significance of the topic of our second speaker, Dr. Brännström, is that until recently, adoption and surrogacy was really the only means for women with absolute uterine factor infertility to have a family. So when the first live birth after uterus transplantation performed by a team in Gothenburg, Sweden, and led by Dr. Brännström was reported in Lancet 5 years ago now, it was not only a world sensation, but this achievement gave new hope for this group of women around the world.
Thank you, Thomas, for setting the stage for our speaker so beautifully. Just a few housekeeping things. Please use the Q&A function for questions and not the chat function, as our panelists will not be checking that. Questions that we don't get to today will be posted on our website after the presentation with the PowerPoint. As always, we are joined by a distinguished group of behind-the-scene panelists to help handle questions and make everything run smoothly. Today's panel includes Giles Palmer, Dara Berger, David Russell, and then of course our esteemed core I3 team. Now, during each I3 session, you always hear the names of these folks helping in the background. So today I thought it would be appropriate to finally put a face to each of the names. So Marianne, if you could please bring up the photo of the rock stars that make up the core team of I3. From left, we have Shaista Sadruddin, Marianne Svestev, and I've been butchering the name practicing all night and I still don't get it, sorry Marianne. We have Jacques Cohen in the middle, very serious about the peace in the world. Thomas Elliott, and then Peter Nage. Nice hairstyle there, Peter. We will be selling posters after the show, and for a small donation, you can even get it signed by the rock stars. But let's get back to some more serious business. It is my pleasure to introduce our first speaker, Dr. Matthew Kemp, all the way from Australia. Dr. Kemp is the head of the Perinatal Research Laboratories of the Division of OBGYN at the University of Western Australia. Dr. Kemp's impressive resume includes PhDs in both medicine and education from the University of New South Wales and Western Australia, respectively. In addition, he is a graduate of Harvard Business School's program of leadership development. And if that was not enough, he also did a postdoctoral fellowship at the University of Oxford in physiology before relocating to Australia. Matt's work blends clinical and large animal studies of fetal growth and development to improve outcomes for preterm infants via the development of antenatal interventions and postnatal therapies. His research has been supported by several national and international agencies, which are listed on his biography on our website. So without any further ado, Professor Matthew Kemp.
Well, thank you, Liesl, for that wonderful introduction. Thanks, Thomas, as well. Actually, I feel like a little bit of a charlatan being here this evening. Thomas is one of the world's eminent authorities on placentas, and Matt's has turned transplanting uteruses into a real art form. I'm going to present a little bit of work that we're doing on an artificial placenta, artificial uterus model, but as I guess we'll find out as we run through our times together, they're very much different, I guess, to what they're doing. This is certainly not, we're not building a placenta, and we're certainly not building an artificial uterus. So just to make that very clear from the get-go. But anyway, this is Great Expectations, development of an artificial placenta for extremely preterm infants. And I've called it that because I think there are some fairly great expectations around this technology, but certainly there's a lot of work to be done in this field. So one of the questions and just a quick disclosure, we of course get funding for this work from a lot of different agencies, philanthropic and governmental, but we don't have any particular conflict in reporting these data. Right, so one of the other themes that we'll be delving into, as much of this work is based around ruminants, and if any of you are familiar with the United Kingdom or Australia or New Zealand, you're probably familiar with sheep and hopefully our friend Sean the sheep. So one of the questions that we get asked quite frequently when we're talking about this work is how long have you been developing or working to develop this sort of technology? It sounds quite futuristic. It sounds like it's sort of been taken out of the matrix. But the reality is that this has been a work in progress for quite some years now. And in fact, as far as we can tell, the earliest published report of somebody attempting to develop an artificial placenta, artificial uterus for extremely preterm fetuses goes all the way back to 1958 when appropriately a group from the Karolinska Institute in Sweden published in Acta Pediatrica a report of supporting pre-viable human fetuses. These are around 375 grams for up to 12 hours using some fairly, by today's standards, I think, unsophisticated technology. And this really got our interest, not only because it, I think, showed there was some legs to this from a human translational perspective, but certainly the technology that was available at this time to do this work is certainly a lot more primitive than what is available now. So that gave us some, I think, real hope that with what we have available now, we can make some progress in this field. So for much of the past 60 years, a number of groups, principally in Japan, Canada, the United States, and more recently us down here in Australia, have been working to try and take this real proof of principle idea and translate it into a new therapeutic platform. I think things have changed a lot since this work got underway. Certainly, what was considered to be an extremely preterm infant in the late 1950s, early 1960s is vastly different, probably by a couple of kilos almost, I would guess, than what an extremely early preterm infant is now. I think one of the other things that's really important to note is that, certainly in our opinion, given the current technical challenges that face the field, we're very cautious about racing to apply this technology to clinical use. And we think that rushing is probably a very bad idea. And we also think it's not feasible. And that's not to pour cold water on this concept, but certainly we're very keen on taking a measured approach here. So in the 20 or so minutes I've got left with you all this evening, I thought we'd break this down into 3 parts. We thought we'd give a little bit of background context, and of course we're working in the preterm birth space. Why are we going to all the trouble of doing this? What's the end game? And this is of course related to improving outcomes for preterm babies and their families. Move on to the challenge in this particular discipline. Why do we need to do this? Why have outcomes for our extremely preterm population not improved in perhaps the same way that we've seen improvements for preterm babies born later in gestation? And then we'll move on to the artificial placenta and artificial uterus itself. Where does it come from? Where do we hope to go next with this particular technology? Now, of course, if you're presenting anything about preterm birth, it's obligatory to show this slide. And I do so really because for a couple of reasons. One, I think that it really emphasizes the fact that preterm birth is an extremely important global health challenge. Thomas mentioned somewhere around 15 to 18 million babies born preterm every year. That's probably an underestimate. Certainly down here in Australia, around 1 in 12 babies are born preterm. In our Indigenous population, that number nearly doubles. And certainly one of the big challenges with preterm birth is it certainly appears to track with socioeconomic disadvantage. We know that certainly in places like Australia, it's the leading cause of death in the first 5 years of life. And of course, just as importantly, those that survive prematurity have a significantly elevated risk of some lifetime disease challenges. We're also finding, I think, some evidence that preterm babies may be at greater risk of developing some of these non-communicable diseases like hypertension and diabetes that we're increasingly concerned about in our populations. So this is a pretty important challenge. Now, one of the good news stories, I think, in preterm birth overall is that really over the past 30 or 40 years, thanks to our OB and neonatology colleagues, outcomes for most preterm infants have improved really pretty remarkably, and that's due to things like much more sophisticated ventilation, exogenous surfactant, and the prudent use of antenatal steroids. However, that's not quite true for all preterm infants, and these data are a little old now. This is from back in 2003, but they still hold broadly true that really north of 30 or 29 weeks, and of course, this is a high resource environment data, your chances of surviving prematurity are really pretty good. What you can see quite clearly, though, as we track back through gestation, certainly down south of 26 weeks, 25, 24, 23, your chances of survival really start to get pretty poor indeed. When we look at some outcome data, and this is disease-free survival to discharge, and this is from a paper published by Barbara Stoll in JAMA in 2015. I think what's really quite clear is that over the past couple of decades, at 23, 24, and perhaps even 25 and 26 weeks, there really hasn't been a lot of movement towards improving outcomes for these extremely preterm infants. Why is that? Well, these are, of course, prematurity is a multifactorial syndrome. There are lots of different moving parts in play. However, one of the, or two, I guess, of the important things that we've really drilled down on for these very, very preterm infants is that one, the lung must be used for gas exchange. That's reasonably self-evident. And two, that the preterm cardiovascular system has to undergo some fairly rapid adaptations outside of the uterus. And I think probably just for this evening, focusing really on the lung. One of the big breakpoints in outcomes is around the sort of 26 to 28 week range. You could see that in those survival data that I showed you previously. We, looking at this, really think that at these very early gestations, in terms of gas exchange capacity, the lung really is not well developed enough to function to support life outside of the uterus. And it possibly doesn't really matter how sophisticated you can get with your ventilation technologies or how many other postnatal therapies you might be able to deploy. If you have no gas exchange surface, if you have a lung that's essentially non-compliant, and if you're not making any of this wonderful surfactant, then really you're going to get very, very poor gas exchange indeed. And certainly at this 22 to 24 week gestation, that's the developmental state for that lung. So really, these guys are too immature to adapt to breathing. So that really led us to start thinking about this problem from a slightly different perspective, and that is essentially at the moment we treat these extremely preterm infants as small babies. Perhaps we can flip this on its head, and instead of treating them as small babies, perhaps we might have a little bit more luck if we start treating them as fetuses. And I guess it's a little bit sci-fi, but this is broadly the approach that we want to take. Now, when I said I feel like a little bit of a charlatan claiming this is an artificial placenta, this is not in any way an attempt to build an artificial placenta. This is essentially ECMO for fetuses. And there are a range of different systems that have been developed or are currently under development in different parts of the world. But broadly speaking, they're all based around the use of gas exchange devices. They're generally passive diffusion membranes that are plumbed in some orientation to either a jugular vein and or the umbilical cord. Some of the circuits involve filters or dialyzers. As I said, there are a variety of vascular orientations that are used. Much of the earlier studies, and I'll touch on a couple of those quickly in a moment, used external pumps or roller pumps to perfuse these oxygenators. More recent work tends to use the fetal heart to drive these systems. And these are all packaged up in an artificial uterus of evolving complexity. And before you get too excited, in most cases when we're talking about an artificial uterus here, we're essentially talking about a large plastic bag. So sorry to disappoint you there. One of the really interesting things about this particular field of research is that there's some pretty unique challenges in here. This work, we liken it a little bit like to a game of snakes and ladders. It's very iterative in nature and you don't get very many do-overs. And we tend to set up an experiment with a particular objective in mind, only to find that there's 2 or 3 other things that pop up along the way that we really hadn't anticipated. So there are lots of challenges in play. We need to rapidly adapt these fairly fragile fetuses to this artificial placenta platform. Of course, we're not just interested in survival per se, we're interested in healthy, disease-free survival. So preventing things like infection and inflammation, maintaining ductal patency, minimizing stress on the fetal heart, and of course, ensuring that there's a normal pattern of growth. These are all pretty key considerations for this work. So before I talk a little bit about the work that we're doing here in Perth in Western Australia and with our good friends at Tohoku University in Sendai, I thought I'd just give you, for a little bit of background, a walk through some of the studies from 1960s through to today. And these are, of course, all animal studies. So the first animal study we found after the Swedish human studies was done by a group in Canada in the early 1960s. They took this apparatus, it looks like it's off the set of Doctor Who, and they incubated this fetus here for a period of about 40 minutes. And this is this animal, again, about 3 months after that maintenance period on this device. So again, certainly shows that this idea has some legs to it with relatively unsophisticated gear. There was a bit of a hiatus really until the Japanese and the Koreans, and certainly at Juntendo and Tokyo University, did a lot of work in this field. So Kuwabara and colleagues did some really pretty impressive work in this field in the mid to late 1980s and early 1990s. In this particular study, They published a 10-day survival. This was using goats. A couple of things to point out, and I guess it's useful to bear in mind as we go through these data, that we're interested in extremely preterm infants. So term in a sheep or a goat is around 150 days. And so these are quite late in gestation. These are also quite large animals. There's not too many 22, 23 weekers that are clocking in north of 2.5, 3 kilos. So these are big, relatively mature animals. But irrespective, these are pretty remarkable results, quite long-term periods of maintenance on that platform. Interestingly, when they're talking about their cause of death, apart from some acute problems with their circuitry, cardiac failure is their major stumbling block at this stage. The next set of work that was really pretty remarkable was done by Uno and colleagues, and this is again in Japan. Again, using goats, they made some pretty remarkable advances, now up to 21 days on an artificial placenta and then 30 days onto a ventilator. So that's, again, a pretty big advance. One of the really interesting things is that we think, given how effective ventilation really is after 28 weeks, that this sort of technology probably only needs to be able to maintain a fetus for 3 or 4 weeks before it's got sufficient time to develop a bit further, get a little bit stronger, and then transition onto some existing technology. So we've got some pretty good progress in the early 90s. The big stumbling block here is respiratory insufficiency. They weren't able to wean these animals off ventilation. When we spoke with Dr. Uno in Tokyo last year, his view was that their use of pancuronium bromide throughout that experiment induced some sort of denervation or disuse atrophy in some of the respiratory muscles, and they weren't able to initiate spontaneous breathing. We skip forward now to the United States, much more recently, 2012. Brännström and colleagues is a group, I think, in Michigan. They're using a sort of a hybrid assisted breathing system. So a little bit of ventilation, a little bit of ECMO. This is a venous pump driven system. Again, really quite nice work, 7-day survival, again, using relatively mature animals. More recently, there's a group at the Children's Hospital in Philadelphia, again, doing some really pretty remarkable work. Again, like our Japanese colleagues, out to 24 days survival. They use an evolving system. I think their most recent iteration is a UAUV system. So that's umbilical vein, umbilical artery, that doesn't involve a pump. And again, we're coming down in size and gestation in our animals. So that brings us up to what we're doing down here in Western Australia. So we established a consortium back in 2013 off the back of some other work that we were doing really with antenatal steroids and postnatal ventilation. And it was a collaboration between ourselves here, this is here in Perth in the west of Western Australia, and our colleagues up here at Tohoku University in Sendai and Nipro Corporation down in Osaka. Nipro is a fairly large Japanese biotechnology company with a strong interest in dialysis. So our aim for this project really is to take this graph and hopefully turn it into something that looks a little bit like this. So a platform that will allow us to deliver healthy survival for even our most extremely preterm babies. So our platform is based around 2 components: our protective artificial uterus or plastic bag, if we're not asking for grant funding money. And this allows us to keep that infant or our fetal sheep warm, hydrated, and hopefully free of infection. And then we have our artificial placenta device, which is attached to the umbilical cord, and that provides our gas exchange capacity, and we have adapters to provide nutrients and medicines as required. So this is a schematic as to how it works. It's all driven by the fetal heart. It's a semi-sealed system. It's under continuous filtration and cleaning. The fetal heart drives deoxygenated blood out through umbilical arteries. We have our gas exchange devices. We're down to a single one now because we've managed to optimize the efficiency of that system. That allows us to reduce the priming volume and the resistance. We have a passive gas exchange. We blend an air, oxygen, nitrogen mixture, and then it returns to the fetus for distribution, all under the power of the fetal heart. So our surgical procedure takes around 10 to 15 minutes, depending on how the umbilical cord is presented in the uterus. Once we have blood flow established, we unclamp all the various hardware, and then the fetus is transferred across to incubation stations. We run, I guess you'd call it a LAM, neonatal intensive care unit. We've reverse engineered some Fisher and Paykel warming beds or cozy cots, and we have that set up and we run that around the clock for a few weeks at a time. So in terms of our history with building this technology, again, we started in 2013. As you can see, pretty serious meetings in Japan. We thought this would be a good idea, so we thought we'd give it a go. Our first work was in 2014. We published some fairly compromised animals, but as a proof of principle study. We spent a lot of time refining the technology with the team in 2015. In 2016, we published a 1-week period of survival in the American Journal of OBGYN. In 2017, we pushed that out to well north of 2 weeks to really stress test that system. So in the past year or so, we've really taken a translational focus on this particular problem. As I think I alluded to earlier in my presentation, an extremely preterm baby in the late 1950s is quite different to one now. So our target market for this particular platform really is a very, very small fetus or baby indeed, probably something around 450, 500 grams. And of course, all of the work that we've done previously and others have done as well was using much larger, much more mature animals. And that's fine from an iterative perspective, but if we're going to really move towards something that can be deployed clinically, it really needs to be able to handle these very small, very fragile fetuses. So in an attempt to do that, we designed some studies much smaller than what had been done previously. We went down to 94 days of gestation. That's broadly equivalent to 24 weeks human gestation. Sheep and humans obviously a little bit different, but somewhere between 550 to 700 grams was our estimated starting weight. Of course, we can't weigh them as we're setting them up, but we think that's about a third lighter than what's been done previously. And we've also managed to pilot a single vein approach. One of the, I guess, dirty little secrets with using sheep for this particular development is that sheep have a very accommodating umbilical vein. They've got 2 arteries and 2 veins. So that means it's very easy to keep a patent circuit while you're messing around trying to catheterize something. And of course, when you're doing that in a human, you won't have that luxury. So we published this paper, I think this is in 2019 now, again, the American Journal of OBGYN, using this technology to support extremely preterm fetuses. This is what our setup looks like. I'm sorry I don't have any video for you. We've had a little bit of trouble trying to get that to work, but you can see our fetus down here at the bottom of that panel. So we set up our experiments very much as if they're basic science experiments. We have a treatment group, because of course these are small numbers because of the nature of the experiments. They're fairly involved and high resource. We have our artificial placenta or EVE group. EVE is our acronym for ex vivo environment therapy. We just call it EVE. So we have 7 in here, 9 in our control group. So we run age-matched contemporaneous controls because, again, we're not just interested in survival. We want the fetuses that are growing in the tank, as it were, to have the same growth parameters and trajectory as the ones that are staying in utero. So we set these animals up at 94 days, approximately gestation, and we took them off at 100. This is a pretty short-term study, but that was deliberate. We weren't sure that these very preterm fetuses would handle being adapted to this technology. And we also know from clinical data that for really, really preterm infants, a lot of their bad outcomes tend to occur in the first sort of 72 hours after delivery. So we thought if we ran that sort of window of experiment, it would allow us to capture a lot of those adverse outcomes without having to spend too many weeks working around the clock watching lambs. So these are some very basic data. These are, of course, at delivery. What we find was that our body weight and lengths and adjusted organ weights were the same between our animals that grew in the tank and that were in control. And that's really good because we know these animals are putting on around 50 grams a day at this point in time. I don't have time to go through a lot of the data in detail, so I'll give you a pretty quick summary just to give you an idea of the sorts of information that we're collecting. But we look at blood flow through that circuit. This is mils per minute per kilo. We were originally anticipating sort of around 250, but these little guys like running a lot higher, but they seem to maintain a fairly normal physiological profile. We've got lots of accelerations and deaccelerations, importantly lactate, which they mark for peripheral hypoxia, is kept nice and low. So these fetuses are doing what we would hope they would do. We do some injury work. I won't dwell on this too much, but there was no difference. This is pretty superficial. So this all looked pretty promising. However, there's still, I guess, a lot of work to be done, and that's because all of this work, our work and everyone else's work, has been done on fetuses that are from otherwise healthy ongoing pregnancies. And I think it's really important to be mindful of that these extremely preterm fetuses that we're hoping to be able to do this work on, they're not coming from healthy ongoing pregnancies. There's some sort of complication, some sort of pathology there that means they're going to be born earlier, and that could be an infection, it could be a growth restriction, it could be placental insufficiency, it could be preeclampsia, a whole lot of different things, but certainly these are not healthy pregnancies. We also need to be really mindful that if we're going to introduce a new platform, then that platform has got to be demonstrably better than the existing technology. And so for a 24-week fetus, that means our platform's got to give probably a 50 to 60% survival chance and at least a 25% chance of disease-free survival. The hard reality is that we have no long-term maintenance or recovery data from fetuses that are adapted to these platforms that are clinically relevant gestation. We have very little information. I'm going to show you some new data very quickly in just a second. From fetuses that have been exposed to a pathology that's relevant to extremely preterm birth, and this is infection chorioamnionitis, FIRS. We've got no non-human primate data, and we have very little information about granular endocrine or organ development. So we have a very long way to go. I'm also cautious, optimistically cautious, but cautious nonetheless, because really our first candidate for this technology is going to be a pretty tough ask. And we think it's going to essentially be a patient that will have no chance of survival on any other life support. And so that's probably a 21 or 22 week fetus. It's probably going to have phenocitis, chorioamnionitis, might be growth restricted. It's certainly going to have very limited cardiac compensation capacity and very underdeveloped homeostatic regulation. So we made a first stab at trying to address this. We've just published this paper. It's online now in the American Journal of OB/GYN again. And in this particular model, we took, again, age-matched fetuses, and we made them very, very inflamed. We did that by injecting, using amniocentesis, big bowls of endotoxin into the amniotic fluid, waited for 48 hours, and then delivered them. And what we found is that these fetuses are profoundly more difficult to manage than their uncompromised age-matched cohort. They suffer from really quite profound hypertension. It's very difficult to manage, and of course that impacts the flow through these gas exchange devices. They're very quickly growth restricted over a 5-day period, and they have really quite noticeable endocrine dysfunction. And so even from these very short-term studies, we can see the growth trajectories are quite different between these very compromised fetuses and compromised fetuses that remain in utero. And so that suggests to us a couple of things. One, that there's a lot of work to be done in this platform to try and get some workarounds to this. But two, that if we're going to be developing this technology, we need to be doing experiments that very closely replicate the clinical picture. And I think we're only just starting to do that. So really to wrap up, before I go too much more over time, are we making some progress? Yes, I think we are. And are we accelerating? I do believe so. Do we have some substantial hurdles to overcome? Absolutely. And although I'd be delighted to be proven wrong, I don't think we're going to be seeing this technology, at least not safely deployed in a clinic in the near future. Just before I hand you back over to Liesl and Thomas, I'd like to acknowledge the wonderful support we get from the NHMRC, from our research foundation. and also our wonderful collaborators up in Sendai under Prof. Massasato, who are just lovely guys to work with. It's a big team effort. Thank you very much for your time.
Thank you, Matt, for that very exciting and thought-provoking presentation. We have a number of questions coming in. I will focus on a few before we move on to the next speaker. You mentioned a number of challenges that this artificial placenta is facing, including the patency, cranial ductus infection, vasoconstriction, and so forth. Could you tell us a little about what are the most important challenges, and how are you thinking, what types of solutions are you thinking to circumvent these challenges going forward?
Yeah, so that's a really good question. As I guess I tried to intimate when I was introducing the experiment, is that this is really iterative in nature, and we will set up an experiment as all good experimentalists should, only trying to change one thing at a time and with one specific goal in mind. And in doing so, we might solve one problem, but we usually unpack two. And so a good example of that is about 3 years ago, we were having trouble keep getting enough oxygen into these animals. The fetuses run on a fairly low PO2, but we needed a more efficient system. So we had a couple of meetings with the team in Japan. We asked the engineering guys at Nipro, please go and build us some membranous oxygenators that were 50% more efficient. They went away. About 6 months later, they shipped us the new oxygenators. We plugged them in, set them up, and they were so good that we weren't able to get the PO2s, I think, under 60 or 70 millimeters of mercury, even just running these things on room air. And of course, when a fetus sees a PO2 that high, it starts constricting its umbilical cord because it thinks it's delivery time. And so that's not something that we could have anticipated, or we did anticipate. So then we had to change our air blending system and start using nitrogen in that mix so we can control those PO2 values. And so that's the sort of thing that we run into all the time with this particular system. So there's an infinite number of permutations, really.
There's a number of questions from the audience in terms of what you actually supplement at the current stage of the model. Jorge Ramirez asking about corticosteroids. There's a questions of surfactants. So what do you actually, in the current version of the model, are you actually supplementing?
So so the lung remains fluid filled. The lambs are completely, and I hope to have a video, but it didn't work. But the fetuses are completely submerged. I guess it's kind of like a Gatorade, Powerade sort of mixture. It's an electrolyte solution with a few other bits and pieces in it. And of course, anyone who has an interest in, I guess, an amniotic fluid composition would probably be horrified that we haven't gone and done high-end proteomic studies on amniotic fluid composition and made a proper one. But so we don't use any exogenous surfactants. This year we've started using glucocorticoids, and that's to help us regulate this refractory hypertension, really. And so we initially started using hydrocortisone. That's not a particularly strong steroid, so we shifted to using dexamethasone. That's obviously it's about 8 or 9-fold higher affinity for the GR, I think. That did give us some good responsiveness, although that takes a little bit of time to kick in. The trade-off is that we're seeing some growth restriction in these fetuses. Now, we're not sure if that's because we also find that there's some dysregulation of IGF-1 and 2 in those fetuses. We think we just really started working this up now, but certainly the circulating levels are quite low. Interestingly, in the inflamed animals in utero, their IGF-1 and 2 levels aren't low. So it appears that these fetuses are compromised in their ability to compensate for that. And again, that's something that we hadn't anticipated. We're not sure that's the reason for the growth restriction, or if it's the steroids, or if it's a combination of the two. But again, this is another example of the sort of challenges that you face trying to put this together.
All right, thank you so much, Matt. For now, we need to move on, but we will get back to more questions and answers in the general discussion section at the end. So thank you so much, Matt. Now it's a really great honor and a pleasure for me to introduce Mats Brännström. He is a professor and chairman at the Department of Obstetrics and Gynecology at Sahlgrenska Academy at University of Gothenburg, Sweden. Dr. Bernstein was awarded his MD from the University of Gothenburg in 1985. And as Liesl already mentioned, Mats and I went to medical school together, but unfortunately for me, none of his brilliance rubbed off on me. Mats defended his PhD thesis in physiology in 1988 at the same university. He then did a postdoctoral fellowship at the University of Adelaide, Australia between 1990 and 93. He subsequently returned to Gothenburg in the Department of Obstetrics and Gynecology, where he quickly rose in the academic ranks as a physician scientist and became full professor in obstetrics and gynecology in 2001. Mats' research interests include uterus transplantation, which we're going to hear about today, ovulation, fertility preservation, and his scientific productivity in these areas has been very impressive, with more than 300 research and review papers in peer-reviewed journals. So today, Dr. Bernstein will be discussing uterus transplantation research and clinical aspects today and then in the future. So please, Mats.
Thank you, Thomas, and it's a pleasure to have this lecture and also to meet Thomas again, because I mean, we went to medical school together, we did our PhD thesis in the physiology department, and I have a lot of good memories to share. So I will tell you about our research on uterus transplantation, and there's a nice connection. It's also with Australia in this story, and I will take that later. Because I was actually an ovarian physiologist from the start. I did my thesis on ovulation, as Thomas said, and I was going to become an IVF doctor. I did a postdoc, a research postdoc in Australia in the early 1990s. I had promised my family to come back to Australia because we liked the country so much. They didn't have a position in IVF, so I had to do gynae oncology, cancer surgery for gynecological diseases. And after some months, I met Angela. She had cervical cancer stage 1B. We had to do a radical hysterectomy, but we could preserve the ovaries. And she suggested to me, can't you do a uterus transplantation to preserve or reverse my fertility? And this was Friday, and of course in Australia you go to the pub on Fridays, and I started to discuss with my colleague, and after a couple of beers we said, well, this is something we should pursue, this line of research. So we looked at the literature, and of course there had been some studies done in the 1960s, 1970s on this aspect, but that was more for transplanting a uterus with the oviducts in order to treat tubal factor infertility. So Angela then belonged to this absolute uterine factor infertility group. She had cervical cancer and lost the uterus because of a hysterectomy. You can lose your uterus at peripartum bleeding or because of myoma surgery, or you can be born without a uterus. It's called the Rokitansky syndrome or Meyer-MRKH syndrome. It occurs in about 1 to 5,000 women. Or you can have a uterus which is not functioning in terms of a pregnancy. It can be congenital malformation. Most of these go with fertility, but some also with early miscarriages, radiation, leiomyoma, or intrauterine adhesions. So this was untreatable before, and it's a fairly large group. It's calculated based on a study in the UK. That's about 20,000 women in the fertile age per total population of 100 million people. So in Sweden, with 10 million people, we would have about 2,000 women with this type of infertility. Of course, all of them would not choose uterus transplantation. They would go for adoption. They would accept their infertility. They would go for other motherhood options like foster mother, or they would also go for gestational surrogacy. This is not allowed in Sweden and in most parts of Europe and the world, but of course Swedish women go abroad to do this. But there is a big interest of this procedure in Sweden. So we started our research when I came back to Sweden in 1999, and we actually followed these ethical guidelines, but they came 10 years after. Especially the first one is that this may reach a clinical stage, but we have to do adequate research and also in large animal models. And of course, I think it helped me that I have this background as a basic research in physiology. I was not a surgical cowboy who would try this in women directly, but I understand if we're going to do this, we first have to see that it's feasible in animal models. So we started with the mouse, moved up large animals, large domestic animals, pig and sheep, and then from 2007 in primate species. And then we launched the first clinical trial on this in 2012. But of course, it's a long time, more than a decade from when we started until we could test this in the human. So we have different models. This shows the primates, but we can have an auto-transplantation model where you would take the organ out from the animal, have it outside the body, and then put it back. So there was no rejection and no immunosuppression. So that is a way of testing the surgery, but you don't test the effects of immunosuppression or rejection mechanisms. You could also have between animals, allogenic between one animal and then to another animal if they're not inbred, which is a human situation except from monozygotic twins, or a syngenic transplantation between inbred animals. And of course we have that possibility in the mouse and the rat. But of course with the allogenic transplantation you need immunosuppression. You have to detect and treat rejection if you get that. So we started with the mouse, and a lot of you have worked with the mouse, and you know it's probably not the easiest way to do uterus transplantation. Mouse has a bicornate uterus, a very small uterine artery. So we developed a model where we actually put an extra uterus, half of a uterus, excluding one horn, with the vascular anastomosis on the aorta and the vena cava. So these are the large vessels, but still the aorta in the mouse is 1.5 millimeter in diameter. So it's a very, very small structures, and you use, of course, operating microscope and 11 sutures. But in 2002 and 2003, we were able to get pregnancies and offspring. This shows the dark bar shows actually the number of pups in the different groups, but this is the grafted uterus, and this is the controls and the native uterus. And so these were the first pups in the world born from a transplanted uterus, but this was a syngenic situation. So we had only tested a surgery and a pregnancy in a uterus with altered position and possibly altered blood flow, not the effect of immunosuppression. We later went up to larger animals. This shows the sheep, and that has a bicornate uterus. We had a simplified model. We excised one of the horns, and we did an anastomosis on the external iliacs. And in this publication, we could see that 4 animals mated, and we had pregnancies and deliveries in 4. But this was still a non-rejecting setting. So we could show in several animal models that the surgery would work. And of course, we studied a lot of aspects, not only surgery, we studied rejection, immunosuppression, and also a lot of what is happening to the fetus after delivery. We moved up to the primate model to get a model close to the human, and that was discussed by the previous talker, of course, also. First, I thought we would not need that, but the advice was that this is not a vital type of transplantation. It's a quality of life enhancing or life-creating transplantation or infertility treatment, and this has to be very safe, and you have to try this in primates before. So we don't have a primate research facility in Sweden, and we wanted to use large primates, the baboons, so we did it in IPR in Kenya and in Miami in collaboration with local groups. And this just shows one type of, we published a lot of papers on this, but of course we get a lot of interesting data. We also always went for the live donor concept. Of course, you can transplant an organ from a deceased donor, a multi-organ donor, but we went for the live donor concept, and the reason was that we were gynecologists, we were not transplant surgeons, and we would not have access to the multi-organ donors in our hospital. Importantly, survival of the live donors, that's of course very important when you do surgery. We could know that it took 3 hours to take the uterus out from the donor, 3.5 to put it in. We could see what immunosuppression we would need, and that is similar to the human, a combination. And importantly, we could detect rejection by taking cervical biopsies. This is the cervix, just the place where we would take a pap smear. So we had several of these publications, and then we were also helped by a Japanese group who demonstrated a pregnancy and a delivery in another primate species, the cynomolgus macaque. This report includes 2 animals only, but one was successful with a natural pregnancy and a C-section, but this was after an auto-transplantation. So at this stage, no one had actually tested what about uterus transplantation in an allogenic setting. We published this in 2014, but the results were already there in 2011. And this was first in the rat model. And we could see that we had, if you compare the transplanted with tacrolimus and the control groups, you can see we got a little lower pregnancy rate, but still full and good delivery of the offspring. And we also, of course, important to follow these offspring, not only to look at the birth weight, but I think that also applies to the previous talk, that of course, it's not only to get a live birth, but you actually have to see what is happening with this offspring later on. And we could not see any effects of the uterus transplantation situation or of the immunosuppression. So we were not the first in the world to do uterus transplantation. I thought when I started my crazy project in 1998 that we were the only one thinking that, but you know, in research there are parallel thinkings. And the first was actually in Jeddah in Saudi Arabia in year 2000. It was done in secret. It was published in year 2002. And it was a live donor case to a woman with emergency peripartum hysterectomy. They had to remove a necrotic uterus after 3 months, and this was criticized, and they had to stop the project, and there was no research preparations. But importantly, I know the people who's done it, she's a gynecologist, and she got the ID, as I did also, from this woman who didn't have a baby and had no uterus. So it was also patient-driven, and that is important. It's not, this is something patients ask for, because it is very important with motherhood. The second one was in Turkey by this guy. He's Dr. Özkan. He is a plastic surgeon. He did the first hand transplant in Turkey. the first face transplant in Turkey and the first triple limb transplant in the world. I had shared a lot of information with one of his co-workers because I thought they were just interested, but what he was interested in was not so much the research, it was of course of being the first one, just like Christian Bernard on the heart. So he did this in 2011 with a deceased donor. This is the patient, the donor. They've had 2 early miscarriages, but no successful pregnancy. And there was probably several technical mistakes due to that they've not been able to establish a pregnancy. So the third case was done in our in the Word. After it was done in our series and was done in 2012. We had a permission to do up to 9 procedures. We would do IVF. Oh, sorry. We would do IVF before, and of course evaluation of the donors and recipients. We would do uterus, and this is to cryopreserve embryos. Uterus transplantation, we would wait a year to do embryo transfer. If there was a pregnancy, we would deliver by cesarean section. And if they only wanted or could have 1 child, we would do a hysterectomy 3 months after, or if they wanted a second child, we would go on to do a second embryo transfer. And it was done here at the university hospital, and was funded not by private research foundations. We had 8 women born without the uterus, MRK age, and 1 having cervical cancer 7 years prior to the study. So she, the same as Angela, who gave me the ID. And of course they were healthy and of fertile age. They were asked, like in kidney transplantation, to bring their own or find their own donor. And we said, well, if you have a mother, if she's healthy and not too old, and has, of course, she would have pregnancies before, she would be a suitable one. Other relatives, or in some cases, the blood group didn't match, or the relative didn't have a uterus, or had not completed childbearing. So in 2 cases, well, one was a mother-in-law and a family friend. And the age was, the oldest was the mother-in-law was 62, and this was a family friend 61, and the youngest was the sister with 4 kids. She was almost 40 years of age. And of course they were informed that this is complex surgery and we are going into the unknown. We don't know if this will work, but of course they wanted to help and also their relatives and friends. And this is more technical, but if you're a gynecologist, if you do a hysterectomy, you will go here inside the uterus to take the uterus out. We would take the uterus, not with any oviducts, not with any ovaries, because they have their own ovaries, but we would not only take the small uterine artery, he would actually go for the complete anterior branch of the internal iliac artery, and also the veins, the uterine veins, which we would take segments of the internal iliac vein. This would be like a extensive radical hysterectomy surgery. And this is what we had practiced in sheep animals. So this, if there are any surgeons listening to this, you can just appreciate this. This is the right side of the pelvis. This is the ureter, which we're very afraid of. And this, in this case, is a uterine vein passing over and going down to the internal iliac vein. This is a surgical field I had never seen before as a gynecology surgeon, and most people haven't seen before, because we don't do this kind of dissection and we don't go as deep in the pelvis. And of course, when we do this kind of surgery, we work with very big surgical loops with magnification and very, very meticulous on the donors, which we should not injure. And then the uterus is taken up on the table, and we flush the uterus and cool it down, and we have prepared the recipient. And this duration of surgery, we thought it would be 4 to 6 hours, because in the baboon it was 3.5 hours. But you can see with the crossbar or the surgery took actually 10 to 12.5 hours. So extremely long surgery. And of course, if we had told our ethical committee that this would take 10 to 13 hours, or the donors before, we would not get a permission. But actually we mispredicted this. But even if they were operate for these long hours, we didn't need any blood transfusion, no intensive care, and this is important because this is of course important, expensive, and they stayed in hospital for 6 days. So the uterus comes out on the back table and we put it in, and this is done by the transplant surgeons. They do the anastomosis of the arteries and veins on the external iliac arteries and veins. As a kidney transplant, but here on both sides. And here we can just see the surgical times of, the mean is about 5 hours. And this is fairly easy surgery. We open up and prepare the recipient, do the anastomosis, fixate the uterus, and then it's ready. These poor women, they had to wait, this poor woman had to wait for 10 hours in anesthesia because, of course, we had mispredicted the time. No ICU, no blood transfusion, and a short hospital stay. And here you can see the uterus. This is the bladder here. This is these are the ovaries, and you can see the uterus from her mother inside the pelvis of the daughter. So they need immunosuppression, and we used it's called induction protocol. You start with ATG and cortisone and MMF tacrolimus, but the aim is then after 12 months to be only on tacrolimus, or possibly also ASA if they have had multiple rejection episodes. And rejection is not like that you lose your organ. It starts with an early inflammation, and if you detect it as an early inflammation, you can often fairly easily reverse it by giving steroids for 1 or 2 weeks. So this was our schedule, and then of course after 12 months we would start to do embryo transfers. This shows a patient, a normal cervix here, where we take the pap smear, and you can see there's this inflammation here in the stroma and in the endothelium. We give this patient cortisone for 7 days, and 3 weeks later we have completely reversed this. So we did 9 surgeries in 2012 and 2013, and 2 of those had to be removed. This has been published. 1 because of intrauterine infection we could not get rid of, and this number 9 because of thrombosis. This uterus was 62 years old. This uterus was 62 years old. And this uterus here, which was the successful first live birth, was 61 years old. So this shows that old uterus may be a little risky to do, even if it can be successful. So we presented the first live birth in the Lancet paper, as Thomas said, and this was then from the 60-year-old 2 Paris woman of this one. And she was 61 years old, the donor, 35 years age, MRKH. She had a single kidney. About 40% of the MRKH have single kidneys. Donor surgery, 10 hours, recipient for 5 hours. This patient had 3 rejection episodes during the 12 months. She was the first one to get pregnant, and we have normal growth curves here with ultrasound. You see the femur length by BPD, AD, and the estimated weight. We were a little worried about the blood flow. This shows the the uterine artery blood flow, and you see that the PI is low, so the resistance is low. and the umbilical artery blood flow is within the normal ranges. So the blood flow was okay, and there was no signs of growth retardation, which we were worried about. She got preeclampsia in week 31 plus 5, and we did a delivery the day after because CTG was affected, and delivered this boy Vincent, who is now more than 5 years old, almost 6 years old, and these are the happy parents. So this was the first uterus transplantation baby. In November 2014, we had the second baby, just a couple of months after the first, and this, nothing special with this, but it's a little special because this boy was then developing in the same uterus as his mother had developed, because this was a mother-to-daughter transplantation. So from these 9 patients, 7 were successful. We now have delivered altogether 9 babies. So 1, 2, and 3 patients has delivered 2 babies, and 3 patients has delivered 1 baby, and all have been of normal weight. A little before estimated type up, first we had tried to do the cesarean section at 35, and then we have extended that to 30, to do it at 37 weeks, and all are healthy today. And of course we have followed the children up very closely. So in this first study, we call it our laparotomy study. We have 100% of, if we only look for the 7 patients that actually got embryo transfers, we have 100% cumulative clinical pregnancy rate, because we have 6 women with babies and 1 woman with repeated miscarriages, some as late as week 22. This is more interesting for IVF people. Clinical pregnancy rate per ET is 32, so that is comparable. The live birth rate per ET is a little low, 90%, but that is possibly due to that we include this patient here. Importantly, take-home baby rate 86%. And this is, of course, shows that this is a highly effective infertility treatment. And then we have to remember this is the first time in the world this is done efficiently. And of course, like all medical treatments, the efficiency and safety will increase. We have done just completed our second trial, which is a robotic trial. It's not a robots that operate, but we use these Da Vinci robots, which actually helps us with a surgery. It's like a laparoscopy, but you're helped by the 3D vision and these robotic arms. So it simplifies advanced laparoscopy. We do the surgery by the robot only for the donor so far, because that is the most difficult part. This shows the ports we put in, and this shows the different surgical steps. But of course, most important is that we have to do very good dissection of the arteries and the veins. This just shows some views. Here is this is the bladder here, and here shows the ureter. This is the uterus here, shows the ureter in front of the bladder. And we are also helped by this, it's called ICG, which is a fluorescent pharmaceutical which you can inject and actually see the vessels within the tissues, so you actually don't harm the vessels. So we have developed this technique step by step in 8 patients. This shows different sub-steps of the surgery, and you can see on the first patient we did in 2017, where we were only able to complete 7 steps out of 12, and then this has emerged. So the last 3 procedures completed within the last years, we've actually been able to complete all the steps on the donor by robotic surgery. And we think this will expand later too, so you can do robotic surgery in the recipient. And of course, the big advantage is that it's laparoscopic surgery. The hospital stay is 1 or 2 days, and you can possibly go back to work within a week. So this is what we have showed, but there are some, we have not been able to show a very much decrease in surgical time yet, but that may come. So these 8 surgeries were performed. We had 1 live birth. This is this little boy here. He's now 1 year old, and we have 1 ongoing pregnancy. So possibly the results will be as good as the first study. So we are not the only one working with this. I just want to point out that the first deceased donor live birth occurred in Sao Paulo. This is the little cute girl, and these are the doctors behind that. And we have close collaboration, so they had been to Sweden to learn the procedure before. So now there are about 75 procedures performed worldwide, and this can be compared to 45 face transplantation, 74 hand and arm transplantations, and these are the countries that has done it so far, not all successfully. These are countries that planning to start. We have speakers from Australia. I know they're planning to do this in Sydney, but also other countries. Live births, we think there are about 26 live births so far, and this shows where, in what countries they are, and if they are from live donors and deceased. Then you see most are from live donors. And that is, it's an advantage to do it from a deceased donor. You don't have the risk of surgery, but it's very difficult to get access of uteri, good uteri with good investigations pre-donation. And we have started also with a basic research project, and that is to create a bioengineered uterus, or first uterine tissue. And you know the principle. You would take stem cells from an individual, you would multiply those, put those on a scaffold, create an organ, a uterus, in a bioreactor, and then you could transplant that into the donor of the stem cells. And of course you would not have a organ shortage, and you will not get any problem with rejection. And this is a principle which you know is used for several organs, and we are far from a clinical solution yet. So this is still on the very basic research stage. So we have done some studies here in the rat, and this shows that we did small tissue patches, and we could actually transplant, by engineered, we could transplant those, and we can get pregnancies, but we could not get any placentation in these patches of bioengineered tissue. We're also working with the sheep. We discussed the sheep to decellularize the sheep uterus, and then in this kind of bioreactors to actually try to recellularize and create a bioengineered uterus. The problem will, of course, be not only to create a recellularized organ, but actually to create a functioning organ and also blood vessels. So the conclusion is that uterus transplantations has repeatedly proven to be a successful infertility treatment, but it's still an experimental procedure. It will stay there for several years, and if it's done, it should be done within clinical trials. We think robotic surgery will be used in the future, and if bioengineered uterus comes, it will take a long time until it reaches the clinical stage. At least 10 years is my prediction. And most importantly, this is not a one-man show, it's a team effort, and this shows essentially the same team working in the sheep 2005, and in the baboon in Africa in 2009, and in the human field. There is a society for this, International Society of Uterus Transplantation, and there are we just launched a book by Springer if you want to get a lot of more details about what is happening in the field. Thank you for your attention.
Thank you, Mats, for an exceptional presentation. I think that the thing you discussed last in your presentation with the bioengineered uterus is super exciting, and you can really envisioning that area of research will actually merge with what Matt is trying to do, so he can actually skip the plastic bag in the future. There's a lot of questions from the audience. I will pick one or two at the most now before the general discussion. Maybe we can start with a question from Turabi Yilmaz, asking whether donor ovaries actually can be included in the uterus transplantation, and if so, what would the advantages and disadvantages be?
Yeah, I think technically they can do, but there are some studies on allogenic ovarian transplantation, and there has been a very big problem with rejection of that tissue, so I don't think it's that easy. And then it's of course a different, it's a different ethical situation to transplant ovarian with germ cells. So we have not done research on that, but if that is going to be done, it has to be, we have to do research in animals to see what the suitable immunosuppressor should be and so on.
Usama Muhammad Mustafa brings up the question about removing the transplanted uterus after successful pregnancies. What's the risk-benefit analysis doing that as opposing to have it remaining?
Yeah, I mean, you should not have it remaining with immunosuppression for many years, because then you increase your risk of especially nephrotoxicity and malignancies. What possibly you could do is that you could just cease with immunosuppression, and we saw that in the animals that you don't really have to do hysterectomy. You can the uterus will just actually become a fibrotic tissue. But interestingly, perhaps you should remove the uterus after 1 or 2 children, and then you have a perfect organ to transplant that to a third woman, because you have already done the big donor surgery. So this is called domino transplantation, and I think that will be a future. An organ can actually be used not for 2 individuals, but possibly for 3 individuals.
Thank you. Liesl, do you want to start off the general discussion?
Yes, thank you so much, both speakers, for the fantastic presentations. So for more general discussions, I would like to throw one out there. Probably both of you can chime in. Most of the audience today is lab specialists, reproductive, embryologists, andrologists, and so forth. And I think a lot of us are wondering if at all in the future, one day, we would be able to completely circumvent the natural in vivo uterus and placenta and just transfer our embryos straight into some artificial device. So could you both maybe chime in on that?
I think, I mean, you should never say no, because I mean, we have said no so much for so many other things in the past, and that has worked, but I think it needs a lot of research. I think we're far away from that, and I think the problem is, of course, early fetal development, and that you actually probably need the normal environment for that to work properly. So it may work in the future, but it will be a long time, I think. That is my prediction.
What do you think, Matt?
Well, I agree, never say never. Look, I think certainly with the technology that we're playing with at the moment, the hard reality is if you can't catheterize it, then the system won't work. And as you'll all be acutely aware, as a vessel gets smaller and smaller, it's generally a lot more fragile as well, but the internal diameter of the catheter that you've got to try and get into it, it gets increasingly smaller, and as you get a much smaller internal diameter, you substantially increase the resistance that you're playing with. And if you're going to have a system that's driven by the fetal heart, that fetal heart, as it gets smaller and smaller, has a much decreased capacity to handle high resistance. So your resistance goes up, your ability to deal with that resistance goes down. You probably can't get in a catheter anyway. Our guess is, and then you've got to have an umbilical cord to play with in the first place. So, my guess is probably that your hard limit is around 20 weeks anyway. So I know a lot of people get very interested in this sort of Matrix style dystopian future where we're breeding vast numbers of children in banks of incubators. That's not apart from being eye-wateringly expensive, and probably technologically unfeasible, I don't think it's a concern with this particular technology, because you simply couldn't catheterize something, and you certainly couldn't drive a head of pressure through that circuit with a fetal heart. And I think if you tried to use an external roller pump, as has been shown for the past 40 years, you tend to damage the heart. So I think there's some hard limits on what you can achieve.
Okay, great, thank you.
A question for Matt. I can see you're starting to fall asleep. It's getting close to midnight in Perth. So to keep you awake, combining questions from Cassie Roca and Diego Escurra, at what gestational age do you envisioning the artificial placenta really will have the most impact? And how many weeks do you believe you have to keep the fetus in the artificial placenta to really have a measurable impact or effect on mortality or morbidity?
Yeah, so the biggest impact I think is going to be on those fetuses that have an almost zero chance of survival or an almost zero chance of disease-free survival. Because again, quality, not just survival, it's not a binary equation. It's really quality of life that we're chasing. And so clearly with I think some of the data I showed earlier, these 21, 22, 23 weekers, and of course this is all high resource environment. If you start talking about low and middle income countries, you shift that curve probably 3 to 4 weeks to the right. But certainly those are the gestational age that the individual impact is going to be greatest. I think, again, this is fairly experimental technology. And again, I'd hasten to add that if you're going to use something, it's got to be something new rather. It's got to be a lot better than what you're replacing. And I think that there is pretty good improvement in outcomes. 28 weeks is still very early, but certainly when you look at the outcomes of a 28-week fetus relative to a 22-week fetus, it's a very different ball game. And certainly even more so once you get around 29, 30 weeks. So certainly the impact is going to be much greater at these earlier gestations. In terms of how you might apply this, I think probably it's most feasible in the short to medium term, and I'm talking about 10 years plus here, probably for a 4-week period of incubation. That said, experimentally, the trouble with these systems generally tends to occur fairly acutely. So if you can get a platform working that's going to work acutely, and then you can really dial in on all of the signaling and growth and nutritional supplementation and everything else that you need to do, it may be not that much more difficult to run something for 10 or 12 or 16 weeks relative to those first 4 weeks. But certainly there's a lot more testing required for that. And I think that would be a much greater proposition, because the argument would be, well, you're now at 29 weeks equivalent. If you go onto a ventilator, you've got 75, 80% chance of survival. You stay on this platform, could it fall over?
Sorry, keep forgetting to unmute myself. I have a question here from one of our panelists, actually, Dara Berger. And this is coming more from an embryologist perspective for MATS, M-A-T-S. I know it's hard to distinguish MAT and MATS on the same presentation. But Dr. Brännström, as embryologists, we're wondering, do you require the patients to already have frozen embryos available before you would even do this procedure?
Yes, we have that in our ethical protocol that in the first study they should have at least 10 embryos, and because then most of those embryos were from our IVF unit, and at that stage we did not do blastocyst culture, so those were day 2 and day 3 embryos. In the second robotic trial, we do mostly blastocyst cultures, and then we require 8 embryos. But sometimes all of those embryos they will not get pregnant on those embryos. So we have done IVF also after transplantation, and that is okay. And we have had several of those births. I think 4 of the 9 babies are from IVF after transplantation. So that is fine.
Did you ever have a case where you did a uterine transplant and ended up not having embryos to put?
Oh yeah. No, we always have it before, but I mean, we had one case of we did a uterus transplantation. She had 15 embryos. She separated the husband, and they separated after 6 months, and they were staying. So what would you do? Well, at that stage, single mother IVF was not available in Sweden, or was not permitted. So she went to Denmark. She did not get pregnant, and then we passed a law 2 years ago in Sweden that single mothers IVF was available, and now she has 2 babies with donor sperms and IVF.
Oh, wonderful.
So I think what you should do in the future, you should cryopreserve some embryos, but also a lot of unfertilized oocytes. Then your options are up there. And of course, you can do this with donated oocytes also. That is okay.
You never know what happens in the future, right?
No, and I mean a big question which I don't want to bring up, but of course that is brought up a lot of times is what about transgender females? Should they have the right to have a transplantation and so on? And that will of course be with donor oocytes. We are not doing research on that, but I know some other groups are.
And that was actually one of the questions from the audience.
Yeah.
So to follow up from that, Dr. Vikas Verma touches on ethical questions, which is obviously relevant, important for all sort of cutting edge novel technologies. And actually, Dr. Verma asked specifically this to Matt, but I think maybe Matt also could maybe chime in. How do you reason in terms of potential ethical questions associated to your new technologies?
Yeah, I mean, I think the ethical questions, and I mean, they are different in different societies. I mean, if you have gestation surrogacy, that is an option. In Sweden, that is an option. But I think if you compare gestation surrogacy and uterus transplantation, I think if you want a child, you should actually take the risk of a pregnancy yourself. You should not put that on another person. And it's also the importance of bonding during pregnancy for the child and for the mother. So I think, at least in a Swedish perspective, it's fairly easy to favor uterus transplantation. And then it's also the discussion about risk-benefit ratio. And of course, we didn't know that before. Now we know a little more about the risks and the benefits. But of course, there will be risks and are risks with this. And we think the benefits are bigger. The ethical question now is also about priority in the healthcare system. Should this be paid by tax money or insurance money, or is this luxury healthcare? And we are not there yet. But in Sweden and in Germany, both countries are on the verge to put this within the health insurance system.
And Matt, how do you see it? I mean, your technology is supposed to be used in this very sensitive borderline period between viability and non-viability. So how do you see that?
Yeah, that's a good question. Look, I mean, I think if you could have asked the same question 35 or 40 years ago when someone was talking about introducing CPAP, and you could have asked Graham Liggins this, 50 years ago when he was trialing steroids. The goalposts for what's considered to be viable and non-viable move as our technology evolves. I don't think that there's a lot of merit in saying, well, this is just a very small baby, so we're going to let this one die. But this one's just a little bit older, so we're going to invest a lot of effort in keeping this one alive. I think I'd hasten to add the technology is not designed to supplant pregnancy and I actually don't think we're trying to really lower the border of viability per se. What I think we are, because again, this hard limit I mentioned, again, essentially if you can't catheterize it, then it's not going to work. But I think that what this will do is to improve outcomes and hopefully save lives for those babies that, broadly speaking, have very, very poor outcomes. I mean, there is the odd 22-week baby that does survive every once in a while. We had a 23 and 1 in Perth not so long ago, I think. So, but broadly speaking, they either don't survive or their outcomes are very poor. So I think the technology is not shifting that border down, it's just improving outcomes for those particular babies. And so I don't think there's too many ethical concerns there. I mean, essentially all we're doing is oxygenating a fetus or a preterm baby using a different technique. So I don't think that's too much of something to get your head around.
Okay, I think we are running out of time. This probably can go on for another hour. It is so fascinating, but I think a lot of us have to get back to the lab, back to bed, or get another coffee. So we've come to the end of our session, and I would really like to personally thank, and on behalf of i3, thank both speakers for excellent presentations and discussions. I believe that as technology advances, our disciplines will eventually collide as we strive to help our patients have healthy babies through a combination of ART, uterine and placental procedures. So thank you also to the panelists and the i3 team for everything running smoothly in the background, and to my colleague and co-moderator, Dr. Thomas Jansson. This was an absolute pleasure, and I cannot wait to try the South African food you keep promising to cook for us. And finally, to the audience, without your support, i3 would not exist, so thank you. We will see you at our next session on Tuesday, June 2nd at the usual time, which is 3 p.m. Eastern Standard Time. And it will be an interview with Dr. Catherine Rakowski, President of ASRM, and Dr. Christina Margie, Chair of ESHRA. That should be a very interesting discussion. Until then, thank you everyone. Have a wonderful rest of your week. Be safe, stay healthy, and see you on Tuesday.